So now it's time for an introduction for our next speaker, Dr. Paul Tierstein. Dr. Tierstein is Chief of Cardiology and Director of Interventional Cardiology for Scripps Clinic and Director of the Scripps Presby's Cardiovascular Institute for Scripps Health. With a primary focus on complex coronary interventions and new technology development, Dr. Tierstein has played an active role in the initial development and clinical investigation of coronary stent procedures, rotablator atherectomy, coronary angioscopy, and the utilization of cardiopulmonary support. Dr. Tierstein pioneered the first effective treatment for restenosis, low-dose radiation therapy, and was one of the early investigators of medicated stents. Recent areas of investigation include new technology for minimally invasive transcatheter aortic valve replacement. Dr. Tierstein recently founded the National Board of Physicians and Surgeons, a not-for-profit organization providing an alternative pathway for physician certification that ensures compliance with national standards, promotes lifelong learning. NBPAS.org is the name of the organization. And with that, we'll turn it over to Dr. Tierstein.
Well, thanks for inviting me. It's great to be given the opportunity to talk about maintenance of certification and what we're trying to do to change it. The title I like for this talk is Boarded to Death, and why is maintenance of certification bad for doctors and patients? I do have some disclosures. I do participate in and direct CME activities. I love CME, and that's a conflict from what with what I'm going to discuss today. And I'm also the president of an alternative board, the National Board of Physicians and Surgeons. I'm unpaid, but that also is a potential conflict of interest for my discussion today. So certification matters. We hear this all the time. Why does certification matter? Stop and think about it. What does it mean to be board certified to you? Well, a lot of legitimate answers. Professionalism, high standards, commitment to excellence. But to me, board certification mostly means I'm designated as an expert in my field. But then think about this. How did you become an expert? Now you're going to probably say, well, I spent years in an ACGME credentialed training program. In that program, I learned from a few special mentors. I spent countless hours caring for patients, reading, listening to lectures, preparing lectures, and studying. Learned from my colleagues. Now, where would the answer, I learned from studying for my board exams, be on this list? Where does the American Board of Medical Specialties come in to our training? Well, it would be on the list. It would be on my list. But it'd be pretty far down on my list. Most of what I learned was in preparation long before I got ready to even study for the boards. But the boards had some relevance to my training initially. Now, once you're board certified and you're an expert, how do you maintain your expertise? Well, your likely answers. I care for a lot of patients. I interact with colleagues. I attend many conferences. I read medical journals. I attend CME conferences. I prepare lectures. I review manuscripts. I perform research, write manuscripts, etc., guideline committees. Where would I participate in a maintenance or certification program be on this list? I don't think it's going to be on the list. I don't think it'll even make the list. And this is, to me, a key issue. We just don't learn from the current maintenance and certification programs. So think about this. What role does each board have in making you an expert? The board verifies your participation in the ACGME training program. Your board verifies your licensure. Your board doesn't really teach you anything. Your board's main role is to compose test questions and grade tests. Your preparation for the initial board exam does play a role in making you an expert, but only a small role. Your participation in MOC, taking computer modules at home, studying for a 5 or 10-year repeat examination, doesn't even make the list of things you do to maintain your expertise. I think most physicians would agree with me on this. Maybe not all, but I think most would. We were all brought up to view the boards as a lofty, important organization, but when you really think about the contribution they're making now, it's a contribution, but it's a small contribution. And we have to really keep that perspective in mind when we make these decisions and we plan the future. So, yeah, certification matters. Does it really matter? Well, expertise matters. Certification matters as a surrogate for expertise. I mean, if it's a marker for expertise. But when we examine our education, we find the boards have a very minor role in creating and maintaining expertise. Certification matters, but the individual boards matter less than we once thought. Now, how did I get into this? I sat down in February of 2014 to do my MOC requirements. There was no question about doing them. I run a CV division, a system-wide CV a cardiovascular service line, and a fellowship program. I'm not very political. Not doing MOC didn't even occur to me. And then I thought I would sit down and spend an hour getting started, and I was baffled. It was so confusing. There are so many different places you need to click to try to find out what they want to do. I got frustrated, and that frustration led to communication with my colleagues, which led to a petition, which now has, I think it has 23,000 signatures on it. I realized there was a problem here that was reaching a nerve here, that was reaching a lot of physicians. But after about 6 months of collecting signatures, I started getting emails asking, what is the update? Has the American Board of Internal Medicine done anything? And the answer is not really. And then it was, Dr. Tearstein, what are you going to do about this? So after about 5 months and 500 hours of unpaid work, we got the National Board of Physicians and Surgeons going, and we'll talk about that in a moment. I think it's important in these discussions to get right to the heart of the matter, which is data. Are there really data to support MOC? And the ABIM, the ABMS, they argue that there are data supporting MOC, but when you closely examine the reports that they cite, they actually reveal the opposite conclusion. And you know, I'm not being tongue-in-cheek about this. If you look at these papers, you will be stunned. And I'm going to show you just a few of them. I don't have a ton of time, so let me just say that there are many more that make this point. So here's a typical example. This is JAMA 2008. This is a commentary in JAMA, and written by Drs. Holmby, Lipmer, and Grenier, and these are members affiliated with the American Board of Internal Medicine, and they talk about how assessing quality of care and knowledge matters, and the relevant quotes I've carved out here. There is evidence to support the link between board certification examinations and quality, and here are the references. So let's look at those references. If you look at the first reference, Dr. Sharp, and you don't have to look very far. Here's the paper. It's in a journal called Academic Medicine. The conclusion of the screened studies, more than half support an association between board certification status and positive clinical outcomes. All right, more than half, that sounds interesting. And then if you look at the detail of the 33 findings, 16 demonstrated a significant positive association between certification status and clinical outcomes. 3 revealed worse outcomes for certified physicians, and 14 showed no association. So 3 revealed worse, 14 revealed no. That's 17. 17 is bigger than 16. So the conclusion is right, but they just have to change the word more to less. Really, among the screened studies, less than half support an association between board certification status and positive clinical outcomes. You see this all the time in these papers. Just very confusing and clearly not a big win for certification in this study that is being quoted by the ABIM. And here are the authorship attributions. This is a family medicine doctor, Dr. Sharp, these authors also are associated. This study was funded by the American Board of Medical Specialties, and the conclusion is few published studies used research methods appropriate for the research question, meaning they admit that in this study that was funded by the ABMS, that the data, looking at a lot of studies, data studies aren't even really done right, and the data is not very convincing. When you look at research studies, it's important to look at initial certification versus maintenance, because it's a different situation. Most of the studies cited in the literature evaluate initial certification, not recertification or MOC. Initial certification is earned for the most part by spending several years in your ACGME credentialing program. The initial exam provided by the ABMS is simply a final exam. It's obviously a much smaller part of the educational process. Should it be surprising, for example, that successfully completing 3 years of training in an ACGME credentialed cardiology fellowship makes a doctor better at treating heart attacks? Of course it should. It's absurd to equate the busy work of MOC, clicking on computer modules for 10 to 20 hours every year, to the many years of training required for your initial certification. So make sure you're looking at these studies, you know what they're studying. So here's an example, a recent example, and this is a poster. The paper was recently submitted, and hopefully it'll get approved and published in circulation. This is looking at the Association of Interventional Cardiology boards. This is my specialty, and hospital outcomes after PCI, after stenting. This is one of the few studies looking at LAPS certification, and it found no impact on patient outcomes following coronary intervention. The numbers aren't that big. This is from the NCDR database, and they divided the physicians up into 5 groups, and the 5th group here are doctors with LAPS certification. These are doctors who didn't recertify 10 years after their initial certification. And you can see the death rate is 0.91. That's going in the wrong direction. They actually have a lower death rate. It's not significant, but it's a lower death rate. So really not a very convincing argument. Another one many of you might have seen in JAMA just recently, looking at the VA, 4 VA medical centers. There were no significant differences between those with time-limited ABIM certification and those with time unlimited ABIM certification on 10 primary care performance measures. So this was a very negative study looking at recertification and MOC. In that same journal, there was another study looking at the association between MOC requirement and ambulatory care sensitive hospitalizations and healthcare costs. And here we look and we see, it's a busy slide, I know, so I'll just point out emergency room visits. So we looked at doctors who were from the pre-MOC period and compared them to the post-MOC period doctors. And here you see emergency room visits were actually a little bit less, turned out, in the pre-MOC period. So this was, again, the p-value is not significant, but it's close. That's actually going in the wrong direction as well. Otherwise, really no differences at all between the 2 groups. So this was sort of a negative one as well. The only thing that was found, and some folks are making a bigger deal out of this than they should, is a very small decrease in cost in the group who were involved with MOC. It's a very small difference. The authors felt that the conclusions were the MOC requirement was not associated with a difference in ambulatory care sensitive hospitalizations, but was associated with a small reduction in the growth of differences in costs. And this is a non-randomized study. It's propensity matching followed by regression analysis. So I wouldn't make too much of the small reduction in the growth of costs here in this kind of a study. But when you look at it, it's even more interesting to look at the authors. Now, there's 8 authors to the study, and everyone with one associated with it comes from the American Board of Internal Medicine. And Dr. Holmby, he's from the ACGME, but he was with the Internal Board of Medicine, the American Board of Internal Medicine, when the study was being done. So there's 5 of the 8 authors here are associated with the ABIM. And then you look at the article information, it's kind of interesting to see that the funder was the ABIM, but the ABIM had no role in the design and conduct of the study, etc. And then if you look at the author contributions, the design and concept was done by these 5 individuals, of whom 3 of them were members of the ABIM, and same for the acquisition and the drafting of the manuscript. So this was really prepared by doctors who were affiliated with the ABIM, and there is a huge conflict of interest there, obviously. My favorite one is this response to the article I wrote in the New England Journal of Medicine. This was an invited perspective, and I gave it the same title as this talk. And I received very interesting email from New England Journal of Medicine about a month after that paper was published. And it was 3 letters to the editor. And these are letters that the editor decided not to publish. They're not going to publish the letters. They said, but they said, Dr. Tearstein, you may want to respond individually to them. And one of them was written here. You can read this. It's a very well-written letter making some points about my article. And it was written by Richard Barron, who is the CEO of the American Board of Internal Medicine. And he writes, however, the commentary omits a comprehensive 2013 meta-analysis, reference number 2. That's this Lipner reference at the bottom. And I read that and I thought, well, gee, what did I leave out? I thought I did a pretty thorough job of looking at the literature for this paper. So I got the paper he was referring to, and it's called Issues and Evidence. And I looked over very carefully, and the results, in general, physicians who are board certified provide better patient care, albeit the results have modest effect sizes and are not unequivocal. Modest effect sizes, I think that means small, and not unequivocal, I think that means equivocal. So this is really not a big win for MOC. The disclosures, this study was supported by the American Board of Medical Specialties. Very interesting. And what they did is they looked at a lot of different studies, at clinical outcome measures, and looked at results, and some showed certified doctors did better, some showed no difference. Some looked at MOC exam scores, so some did look into MOC, not just certification. But it really was not a meta-analysis that I missed. In fact, the review limitations say a meta-analysis was not done. So it's not a meta-analysis, it's an equivocal literature review. It's written by an ABIM affiliate. And, as was pointed out to me, it gets a little worse. The paper was published in a supplement to the Journal of Continuing Education, sponsored by the ABMS. And here's the introductory article written by Dr. Nora, and the ABMS is pleased to sponsor this supplement. So this is a paper that didn't really show much to support MOC, yet it's held out as supporting MOC by the American Board of Internal Medicine. And it turns out the paper was written by ABMS affiliates, ABIM affiliates, and was published in, sort of self-published, in a supplement sponsored by the ABMS. So this is really not a good example of a lot of things. In fact, this title from Dr. Nora, Professionalism, one of the things it's not a good example of is professionalism. It's just the opposite of professionalism. So do we really need more data? Well, in the debate, I keep hearing calls for more data. More data sounds good from the podium. It looks good in print. It always sounds good to say we need more data. But think about it. What kind of data quality will we ever be achievable? Are we going to randomize physicians to MOC versus no MOC? Are we going to do this blindly? It's not possible. The data will always be registry data with massive bias. In my opinion, if you ask for more data, it's a cop-out. You're kicking the can down the road. It reminds me of the way I usually describe trials like this. That there's a holy shoot trial, which is Group A versus Group B. And I've thought about how to power a trial like this. You don't need a lot of patients. The primary endpoint could be mortality. It'll cost very little money. We figure with about 40 patients, we'd have a good power to prove that Group B is inferior. And probably your data safety monitoring board would halt the trial early because of excess deaths in the treatment group. Now, obviously, I'm just putting this up here to make a point. And the point is you don't have to randomize everything. You don't have to randomize parachutes. If you have 23,000 physician signatures on a petition saying MOC is not meaningful, maybe you don't need a lot more data. Think about that. Now, I'm a big supporter of continuing medical education. Why is it better? First of all, continuing medical education is not going to a steakhouse for a pharmaceutical company-sponsored dinner. That is not CME. CME has to be regulated by a accredited body that's regulated by the ACCME. Some of you have been involved with this. You have to do an educational gap analysis. You have to have a needs assessment, speaker conflict of interest, course evaluations, all kinds of performance standards. And it's really not to be equated with a drug company event. It must be independent of commercial interests. One of the things I like about CME is while MOC focuses on established knowledge, CME can include future innovations. That's what I want to know. How to keep the physician on the cutting edge. I don't want to go over guidelines, which are probably out of date by now. CME offerings are highly competitive. If my course attendees don't get anything from it, they'll go elsewhere. So this is quite different than the kind of monopoly that the boards have on MOC. Now, let's talk about the exam. This is one of the most controversial points. And it's taken, my thinking about this has changed quite a bit. I initially thought we're going to have to do a recertification exam along the way. It's really no way to not do that, I think. And then I started listening to people and thinking about it carefully, and I really changed my tune. Some people think it's important, but here's the arguments against testing. The exam questions, for most of us, are not relevant to your practice. They usually, the part you have to study for relates to parts of our specialty that we don't practice. Otherwise, I wouldn't have to study for them. This is how it was for me. I think that there are some docs, particularly if you're, maybe if you're a generalist, maybe you feel like you need to learn everything and there's really no box around what you want to learn, and then maybe this is helpful to you. But for most of us, it's kind of interesting to study for these tests, but what we remember, what we learn, we usually forget right away because we're not using it, and that's why we had to learn it again in the first place. We only study what we don't know. We don't know what we don't use, and after the test, we soon forget it. Test questions are often outdated. I know they try really hard to do a good job, but it's not easy to do because things change quickly. Most of the studying is done to learn the best answer for the test. We've all been to the review courses where they say, well, you wouldn't want to practice this way, but for the test, this is the right answer. You hear that all the time. And that's, so often the test doesn't have best practice on it. The test often uses guidelines, and guidelines often change. They often reverse. So rethink your thoughts about the recertification exam, and it's really not that relevant. Also, it's a closed book test, secure closed book test. Well, that's not how we practice. Anything I don't know when I'm taking care of a patient, I've got a colleague to ask, and I've got my iPhone, and I can get the answer pretty much immediately, and I do it all the time. So I've become no longer a supporter of a recertification exam. I just don't think we need exams. I don't think that's a good way to learn. Now I hear this, don't pilots have to maintain currency? Don't we want our doctors to be at least as competent as our pilots? Well, I'm a good one to respond to this because I'm a pilot. Those are some of the planes I fly. The middle picture is my Facebook picture. And let me tell you how this works. We have flight reviews every 2 years. They involve at least 1 hour of ground flight training and 1 hour of flying with a certified instructor. Now, we get to choose the instructor. So I get to decide who it's going to be. It's going to be someone I'm going to learn something from, somebody I want to spend what usually works out to be about 4 hours, or half an afternoon, or most of an afternoon with. It's very practical. There are no written exams or computer modules. You can't even fail. It costs about, depends on how much the instructor charges. Some of them charge $50 an hour. Some of them could even charge up to $100 an hour. So it costs a couple $100 every 2 years. If you're a commercial pilot, it's a more intense requirement, but it's still based in practice. There's not written exams. It's something very practical. Importantly, it's not a waste of time. Now, this is something to think about. If every 2 years, a doctor whom we selected and respected works side by side with us for a day, I think we would love it. And I don't think it's totally out of the question to move to something like that, to have some doctors in your community that are designated examiners, and they can spend a half day with you, not asking you questions, but watching you practice. I think that you would learn something from that, and I think the examiner would learn something from you. And so that's not totally out of the question. I think that the aviation is always a good way, always a good model for medicine. What about costs? Costs for one specialty begin at about $190 to $256 per year, depending on the specialty, plus fees for the modules. And the costs increase significantly if you have boards in multiple. I have 3 boards. On top of this are the costs for the review courses, the travel to review courses, and really importantly for the practitioners, time away from practice. Which brings us to the issue of money. So when I first started this, I had no idea about the quantity of money involved. And it's not my main argument against MOC, but it is an argument. And it has to be understood, I think. And you can get that $9.90. A lot of people don't realize how easy it is to get information about not-for-profits. If your hospital is a not-for-profit, just put the name of the hospital in, and then $9.90 in a Google search, and you'll get the salaries, and you'll get all the economics, including the salaries of your CEO, and I think it's at least the 5 highest paid members of the organization. So the directors here are well paid. This is the ABIM I'm talking about. Now, I have had to tighten my belt in medicine. I spend a lot of my administrative time trying to cut costs to keep our hospital in the black. And that's a very important part of my job, and it's hard. I don't hear patients demanding MOC, but they are demanding better value, which means better care at a lower cost. And I think physicians now are asking the boards to do the same thing. You're going to have to tighten your belt. That means you're going to have to make do with less secretarial support. that means you're going to have to make a lower salary, like all of us are doing in medicine, and not a higher salary. Meanwhile, for the boards, all the prices have just increased throughout the whole economic downturn. Everything just increases. And these organizations are doing very well economically. I think it's time for them to tighten their belts, unfortunately. This is the 2012 990 from the American Board of Internal Medicine. You see $55 million there as the budget. And these are the highest paid executives. And I bring this out. I mean, the highest paid executives are getting a lot of money. But I thought it was interesting when I went down this list. I saw these two names, Holmby and Lipner. I thought, gee, I know those names. Oh yeah, those are the authors of all the papers I've been reading. They're telling me how great MOC is. And I was shocked to see their salaries. $450,000, $380,000, and these are the doctors that are writing the papers to justify certification. And they're not just affiliated with the ABIM, they're highly paid executives, highly paid doctors at the ABIM. And I think that's just wrong. And this has to change. You can't have highly paid executives of a not-for-profit organization writing papers supporting that organization and being paid like this. It's not right. It's not professional. So beware of economic and other COIs. There's a lot of conflicts of interest. Many organizations, very good organizations, do make money from selling MOC study and design and testing materials. And many leaders of medical societies have friends and colleagues associated. I think that's even a bigger issue. You know, I know people at the ABIM and ABMS boards, and you know they're your friends and colleagues. And I think it's important that you tell your friends this has to change. You can't just support them blindly. I just happened to get what I posted at the bottom here by email yesterday. This is a group that I love, the American College of Cardiology. I'm working with them. I'm working with them to even reform MOC. I just got an email and I just cut and pasted it here. Are you participating in an ABM maintenance of certification program? Well, take advantage of ACC's offerings. So this is a conflict of interest, and we have to recognize it and I think deal with it. Now, a lot of you have seen the Newsweek article that focused a lot on the economics. I think it's just one area, one example of the pressure that's being put under the ABMS and ABIM. In response, ABM has done a fair job, at least saying that they're going to make some changes. And this apology, I think, was a very good idea. It was a good apology from Dr. Barron. Basically, the first step here is that Part 4, which is the really onerous practice improvement modules, patient safety modules, that was suspended. That's a good decision. However, the other changes really have not been meaningful. The change in the public reporting language of the diplomatic status, that's nice, but not that important. They froze the fees. That's good, but they should reduce the fees. And they promised to consider further changes. And we get an email about every, 3 or 4 weeks from Dr. Barron, basically saying that he's listening and they're studying things. But we're still left right now with parts 2 and 3, which are the modules, and then the secure recertification tests that I think are really needs to go. The self-admitted poor rollout of MOC by ABIM, I think, illustrates the need for an alternative certifying organization. And interesting, applications for our organization triple actually after this apology, and pretty much every time there's an email from the ABIM, we get more applications. It's kind of interesting. So the National Board of Physicians and Surgeons, what is this? It does not replace the ABMS boards. We're not against the ABMS. And we actually support the initial ABMS certification criteria, which is completion of an ACGME accredited training program and a secure test. We strongly object to the current MOC requirements, but we believe in choice. If you benefit from MOC, do it. But we think there should be alternatives. Lifelong learning is not one size fits all, and no single program will meet everyone's needs. We provide an alternative. Now, these are the detailed criteria for the NBPAS certification. You can't read it, so I've extracted it here. This is in a nutshell. You have to be previously certified, as I mentioned. So in a way, the National Board does require a test, just not a repeat test. We require the initial test that you got when you did your initial board certification. We check on your license to practice medicine, and you have to complete a minimum of 50 hours of ACCME accredited CME within the past 24 months. That's our substitute for all the modules. We think that CME is a better way to go. If you're in a procedural specialty like surgery or interventional cardiology or electrophysiology, we want you to have active privileges to practice that specialty in a licensed U.S. hospital. That's how we deal with the case number issue and whether you have enough currency in that procedure. And additionally, your clinical privileges in your specialty must not have been permanently revoked from a hospital. That's the criteria in a nutshell. The board members are very well respected, high profile members of the academic community. They're listed here. They come from the Mayo Clinic. They come from Harvard. They come from Dartmouth, Cedars-Sinai, Columbia, Scripps, UMass. These are high profile thought leaders. And I have to mention that this movement to change MOC cuts across town and gown. It cuts across the whole academic versus primary practice issues. The academics are just as upset about it as the practicing physicians. And think about it from an academic. Think about it from a bench, from a researcher, basic researcher, spending 4 days a week in a lab and 1 day a week seeing patients. It's quite a commitment you're asking for them to do MOC when they're only spending 20% of their time clinically anyway. The website, we've worked hard on it. We think it's simple to navigate. If you find problems, let us know. There's a lot on that website. We've worked so hard on it. There are links to articles. There are links to sample letters that you can download, personalize, and send to your hospital administrator, send to your colleagues to get them involved. There are links to downloadable PowerPoint presentations. Presentations like this, you can see a video of it, and you can also download the slides. And you can download a shorter 15-minute slide set to use at your medical executive committee. This is an example of what it looks like. It's pretty simple. It's pretty clean and crisp. You know where to click. Takes probably 10 minutes to do the whole application. If you have your PDFs of your CME activities. You do have to have those. That's the hardest part. You have to pull together 50 hours, evidence of 50 hours, and then you have to learn how to upload them to a computer, which many of you know how to do. If you don't know how to do that, find someone to teach you it. It's a skill you need to learn. I think you'll be interested to know that the American Board of Medical Specialties and the AIBIM will give us the information we need to find out if you've been previously certified, but we have to pay them. If you're a patient, you don't have to pay, but if you're a professional organization, you have to pay. All of your hospitals that you work at pay these organizations to find out if you're certified, to validate it. So they're getting paid every way they can. The NBPAS is a not-for-profit 501c3 organization. The cost is $169 for 2 years, so it's about $85 a year, irrespective of the number of specialty applications. It covers 2 years and all the specialties. The fees, what do we use them for? We've got to validate all of this, and we're not paying any of the doctors, but we have now 5 people on staff, and we're growing, and that's what we're using the fees for. I think we're going to be able to reduce the fees in coming years, though, because we're doing pretty well. Please go and view the website and apply, leave comments, and help us make it better. It's nbpas.org. We do need your help. All right, go and apply. At this point, we don't even want contributions. It's a not-for-profit. We could take contributions, but we don't want them. We'd rather you just apply. We have just over 2,000 applications now. I'm very proud of that. That's been about 5 months. We'll probably, at this rate, because we get applications every day, at this rate, we'll have over 3,000 by the end of the year. But we're counting on physicians like you to jumpstart this organization. Importantly, at this point in time, we need you to lobby your chief of staff and your medical executive committee, your credentials committee, and board of directors. We need to make certification by NBPAS a alternative to certification by ABMS. That's the key. And use the resources on our website, the PowerPoints and sample letters to do this. We're counting on you. Here's the simple message. Change your hospital bylaws to make NBPAS certification a valid alternative to ABMS member board certification. We now have 10 hospitals. Some of them you've heard of, some of you haven't. Most of you have heard of, for example, Baylor, Texas Heart. In our neck of the woods, Hoag Hospital, in Southern California. It's a process, and I haven't gotten it through scripts yet. It's going to take more time. I've already presented to 3 or 4 committees. We have 5 hospitals. It's complicated. Changing the bylaws requires usually the Board of Trustees vote, and that takes some time. And these committees meet generally once a month, so it takes some time. But we need to have at least one individual at every hospital who are motivated to make this change. I think in closing here, Dr. Loader wrote a really nice editorial in the British Medical Journal. I think she says it very well. She says physicians have learned they have real clout that organized effort can overturn something they saw as inevitable. Look for this to be the first of many doctor-led revolts. I think that's very interesting because this has opened a lot of our eyes. This is my fantasy New York Times headline, breaking news. Physicians finally extract heads from sand. Docs came close to ceding control of entire profession. So the point is, this has been a sentinel event for many of us. We're waking up to the fact that our profession is controlled by folks that are not always involved in patient care. Initially, when confronted with the inequities of MOC, many reacted with jaded pessimism, saying, it's too late, MOC is here to stay, the horse is out of the barn. But the ABAM is certainly making changes, and alternatives have appeared. We can and will put the horse back in the barn. It's time for practicing physicians to take back the leadership of medicine. Thank you.
Dr. Tierstein, Dr. Judy Thompson here. Can you hear me?
I sure can. How are you?
I'm well. How are you doing?
I'm good.
Good. Thank you for your informative presentation. And personally, I really want to thank you for your excellent demonstration of leadership for those of us around the country. We have about 25 minutes to talk here. Perhaps during our conversation, Kurt Eichenwald from Newsweek will be calling in. So hopefully if we can get him online, he'll be participating in the conversation.
Okay.
I'm going to start with a question, and that is, you told us that the ABIM has made an apology and suspended Part 4 of MOC. Their fees have been frozen. What's next for them? Do you know?
Well, actually, they did something last week after we taped that. They revoked or reversed the requirement that we currently have, that they had, which was that if you wanted to be certified in a subspecialty, you had to also be certified in the underlying specialty. There were 9 subspecialties that had this requirement. So, for example, I'm an interventional cardiologist. To remain certified in interventional cardiology, I had to do MOC both in interventional cardiology and also in general cardiology. So that was a lot of work, a lot of things that were pretty irrelevant to my practice. And so they suspended that requirement. That's one thing they've done. And I have a problem with that. I think it's good because a lot of people, by choice, a lot of people do not want to do cardiology. Or same thing in the sleep. I think you had to do, if you were a sleep expert, you had to still do your pulmonary MOC. The problem, of course, is that a lot of us practice things like interventional cardiology, but we also practice cardiology. I see patients with atrial fib, I see patients with CHF, and So if I give up, I no longer have to take the MOC in general cardiology to remain certified in interventional cardiology, but I give up my cardiology certification. I worked hard for that, and it seems kind of unfair. So theoretically, if I chose to give up my underlying cardiology certification, if I ever got sued during the treatment of heart failure, the patient with heart failure, I suppose the lawyer could say, hey, what are you doing treating a patient with heart failure? You're an interventional, you're not a cardiologist, you're an interventional cardiologist. You're supposed to be sending them. So I think that's a change. It's one of these things with unintended consequences, and one of the problems of MOC. What's next for them, what they've said they're trying to do is improve the test questions. They said they're going to try to make CME count for some or more of the MOC process. I think what they're going to end up doing is having a system where if, I suspect it's going to be that if your CME provider has the program approved by the American Board of Internal Medicine as qualifying for MOC points, then you'll be able to get some points for it. Which of course, means you're going to have to get your programs approved, which means you have to pay and get another revenue source. So, I mean, it's not all. I think these are improvements, but they're imperfect improvements. I think the crux of it is the real problem I have with MOC is the testing, is the test that's required every 10 years and all the modules that are required. Because these are really, most of us consider this busy work. You do have to study for these tests, you might think that's good. You're learning things you don't know, but the problem is you're learning things you don't need to know. If you needed to know them, you would have learned them.
Mm-hmm.
So, you would have already known them. I mean, if you need to know them, you learn them. I mean, we all do that all day long for our practices. So, and I don't think that they're going to really ever dispose of these tests. It's going to be very hard for them to make that decision because that's where they make their money. That's their core competence. That's really what they're in business doing. They're not teaching you anything. They're in business to give you a test. So they're going to want to give you tests. This is my pessimistic, jaded attitude about this perspective.
Well, thank you. I'd like to extend a comment from our audience to you. Dr. Stephen Croft says, thank you for your leadership. And then Dr. Claire Coco asks, are most members dual certified? And by members, I suspect she's asking NBPAS.
I don't have a statistic for you. We have over 2,000 now, and a lot of them are certified in more than one thing. A lot. I mean, more than half. Good question. I need to get the statistics on exactly what specialties and all that.
Okay. Dan?
Well, thank you, Paul. Dan Cravioto here. Thank you for your leadership on this and for your scientific approach to it. Basically, I enjoyed your presentation immensely, how you just walked us through step by step with sound reasoning and logic for your reasons for believing in this. And the biggest issue for us is we have brought that up to our hospital initially, and the staff privilege thing is a big thing, but I'm sure we'll come back to that again, but any thoughts on that? You kind of already mentioned it. There's letters you gave us and all of that we can pursue, but I imagine across the country that might be the major issue right now, correct?
Yeah, that's our focus right now. We have 11 hospitals. I don't know if I put them in my talk yet or not. Because it changes every week. I'm going to send another mass email blast out this week, so I'll probably learn. I'll get some responses, and maybe hopefully we'll get up to 20 soon. The most well-known hospital is Baylor, the Texas Heart Institute at Baylor, that have accepted NBPAS. It's a process, and it's not easy because you have to change the bylaws of your hospital, and that requires usually the medical executive committee and or the credentials committee. The committee members are physicians, and they are, for the most part, very sympathetic. But then you get one or two, like 10%, that are not. Often they're surgeons whose own specialties, own certifying organizations have not embraced MOC. They don't really understand what an ordeal it is. And they're a little resistant sometimes because they think, well, if we don't do testing, no one's going to believe it, so we just have to do testing. It's not so terrible. But what's really true is theirs are not so terrible. But some of the others, particularly some of the internal medicine ones, are pretty onerous. So that's one thing to overcome. The committees meet monthly. They don't usually just approve it. They want to meet, talk about it again. So usually there's a 3 to 4 month process every committee. And my hospital has 5, 6 committees, so we're still going through it. I was told that I shouldn't expect much until after Labor Day, when the committees start meeting again. So it's just a process. The lawyers sometimes have issues with it. Right now, one of the issues is if you want to be a program director for a fellowship, you have to be board certified. And the board has to be ABMS board. That's per the ACGME, the American College of Graduate Medical Education. So I've got to get that changed. I think I'll do a better job getting that changed once we have more hospitals on board, though. So it's kind of a chicken and egg thing. All I can say is fine. I am a big fan of petitions. Get a petition. You can modify my letter that's online into a petition, or you can take the petition that's online at Petition Buzz. If you just Google no MOC, you'll get to it, and do it in your hospital so they understand how important the issue is. It's very, very common for a medical director, particularly one who's not practicing, who doesn't go through the MOC process themselves, to not really understand this. And they'll say, yeah, we'll look into it. And then nothing will happen until they start talking to other doctors. Usually it's because they go to a doctor themselves for personal treatment, they mention it, and the doctor starts going ballistic, upset about it, and then they get serious about it. That's what happened in my hospital. But I'm still not through the process at my hospital. It's still going to be another few months, I think.
Dr. Tierstein, Mike Strickland here. I want to say I've been really looking forward to hearing from you and getting a chance to speak with you. And thank you for your tremendous efforts and leadership here. Our experience in putting on this conference has enlightened us into just the incredible amount of, as you said, hundreds of hours of unpaid time and dedication that you've demonstrated. And especially the fact that you have and your group have made a real world difference for doctors. You're not complaining, you're doing something about it, and you're really having a tremendous effect. So in light of that, I wanted to ask, to what do you attribute the ABIM's change of course and its willingness now to listen to physicians at large? I assume that your group's effort is central to that change, but if there are other things playing in, let us know. And what lessons are learned there for the other problems that are plaguing physicians?
I think that's a great question. So first of all, ABIM has made significant changes. They really have, and I think they're going to make more changes. If they don't, they're not going to be in existence, which would not be a good thing. By the way, other boards besides the ABIM have made changes too, although you don't hear about them as much. Partly because they made sure they got started on the right foot. They didn't have a misfire because of this experience at the ABIM. So we've influenced a lot of boards. Now, what's responsible for this? I think the main reason for the change is that the physicians have made their voice very clear through a lot of pathways. I don't really care much about taking credit. I think I'm doing fine. I think it's sort of humorous the way all the societies have taken credit for the ABIM changes. I think it's actually a little risky because some of them, in fact, my society, the SCI, which I believe strongly in, I think it's a great society for interventional cardiology, said now, once they made this latest change last week, they said now ABIM has approved all 4 changes that we want. And I think that's great, but it's not enough. It's not even close to enough. So, ACC also took credit for this. And I think they deserve some credit because they were responsive to their membership. They heard their membership ask for this. Now, how do they hear the membership? Well, I think the petition that we initially did that has 23,000 signatures, and could have more, we just stopped emphasizing it. And of course, I don't think it's a coincidence that when we launched the National Board of Physicians and Surgeons, literally 10 days later, we got the big apology by IAM. That was the mea culpa. And I think that's good. I mean, this is a good thing. We were able to help bring about this change. Now, there is a lesson in this that I think we all learn. And I said this in my talk, but I really should re-emphasize it because I'm kind of stunned by it, and in a positive way. I got a lot of pushback initially, and this was online. I don't think I have the time to go into this during the talk, but online, we have a wonderful email, I think it's called a listserv in the jargon, in interventional cardiology. It's about 120 program leaders, and was organized by a guy named Mort Kern, who is the chief of medicine at the Long Island, not Long Island, boy, the Long Beach, New York roots, the Long Beach VA. And if there's a clinical question you have about a patient, not sure about blood thinners, you're not sure about a certain anatomy on a coronary angiogram, you can submit the question to Morton, even with and add the images if you want, and then he'll send it out to the 120 of us on this list, and you get consults, and they're really good by very smart people and often very well-known people, and you get them very quickly. Maybe you'll get 20 or 30 responses, and we all get a little educated by it. It's a great idea, and for those of you, not in interventional cardiology, it's not a bad idea to start. It's very valuable, I think, service, and you learn a lot, and it's kind of fun. We've even done some publications, we've published some of our conversations, we call them, email dialogue. So I simply got online to try and do my MOC, because I figured I would do it. I figured I got to do it. I'm running fellowship programs, I'm running divisions. I got online to do it, and I was so horrified by the process, and so upset by it, that I just wrote an email to the group of 120 on my list, and I said, has anybody else tried this? This is ridiculous. We got to put a stop to this. And most of the responses I got were, Paul, the horse is out of the barn. There's nothing you can do about this. This, it's going to be a waste of time. And I basically started the petition just out of guilt, because I felt like I better do something, I was surprised to see so many people respond so quickly. And then when we started the new board, we didn't start the new board because a lot of people signed this petition, thousands and thousands, but then the ABIM didn't do anything. So we did the new board, and that got a lot of response just through social media. We're just now discussing whether we should do advertising. Maybe you can give me some feedback on what our next steps should be. But we clearly can make a difference. And that's sort of the take-home here, is that you really can get your voice heard. I think you need to do it. You need to use social media. I think you also need to not be crazy. And you need to be thoughtful and be aware that you're talking to a big audience. And physicians, they all have these, everybody's got a definitive idea. If I should make a list of the solutions to the MOC problem that I've got, the detailed solutions written by doctors in emails to me who say, now look, I know how this should be. And they write a solution that's completely different than someone else's and will be objective. Everyone will have so many objections to it, but physicians are very opinionated. So don't think you know everything. You have to sort of listen while you talk. And you can't call the people that you're trying to change idiots. You have to kind of be, you have to be respectful and realize that you're probably not 100% right, that they're not as wrong as you think. Because the physicians that are a little too aggressive, then what happens is they may be totally right. And there's several physicians that I've become friendly with that are very aggressive about this. And they're sort of right, but I think the way that they convey their message just turns people off. Because they sound too emphatic about it and too sure of themselves. And they never give the other side credit for any of the change that they're making. So it becomes almost like politics in the United States today. You don't see a lot of Democratic candidates giving a lot of credit to the Republicans and vice versa for the things that they do believe in. It's always negative, negative, negative. So I think you should try to be positive and try to make a change and try to get your ego out of it. You don't need to take credit for everything. What's important is the change, not your ego. So those are my thoughts. I would like to know what you think I should do next, and what NBPAS should do, because we were thinking about maybe advertising in JAMA and in New England Journal of Medicine, I'd like to figure out a way to expedite hospital approval, and I'm not sure how to do it. I mean, it would be nice if I could run around and speak to every hospital MEC, but I really can't do that. It really has to come from the hospital physician, I think. There are a few legal things that we could do. We could lobby we can lobby maybe Congress to make sure the Affordable Care Act doesn't somehow require MOC. But I don't know. Do you have any thoughts about what do you think of advertising? If you saw an ad for, and you become board certified, and sort of a couple of bullets about why MOC is good in JAMA, if they would print it, if they would take our ad, do you think that's a good idea?
I do think that's a good idea. What about Sermo? Do you advertise there at all?
No. That's a great idea. I didn't even think about that because I'm not on Sermo.
Well, I think they have about 350,000 members now. And I did want to say, I heard the...
Right.
Go ahead, sir.
No, that's a good idea. That's a great idea. Yeah.
I have heard the exact same comment that you brought up from people as we were organizing this summit, and that is the horse is out of the barn, there's nothing you can do about it. And I just want to say to those people, Dr. Tierstein and his group have proven that is not the case. And I also want to say, and if you go on Sermo, Paul, you'll hear and see probably hundreds, if not thousands, of people complaining about MOC and other issues. And I just want to say to them, Dr. Tierstein and his group have done such a tremendous effort to get this thing off the ground and into orbit. We talked about our own project here is like going to the moon. And the tremendous thrust and effort it takes just to get off the ground and into that first step of orbit has been done by you and your group. So to the rest of you that are complaining about this issue, here is your chance to not have to do that yourself, but to just take your own small effort and help get the rest of the way there. And you can do that by signing up, by certifying with the NBPAS. As everyone has said here, you can be dual certified. There's no prohibition there. And to talk to your hospital about recognizing that certification.
I actually, thank you for saying that, but I just realized I didn't understand the first question. By dual certification, I thought you meant certified in more than one specialty. You're saying dual certified both in an ABMS member board and the NBPAS, correct?
Yes. Yes.
Well, they all are, because you have to at least have been, let's put it this way, to be certified in the national board, you have to at least at one point have been certified by an ABMS board member board. That's a really important point. I mean, we're not doing away with that initial certification, and so the majority are dual certified. But some people are signing up with us just to make a statement, and it's $85 a year. Probably going to go lower. We're doing this. We're not spending lavishly here. I do want to make that point, that make sure everyone understands that. And when your hospital committee says, "Gee, there's no testing involved," you can say, "Yes, there is testing involved. The initial test, we're okay with that. You do your fellowship, you do your residency program, you take your test, but you don't have to take follow-up tests. That's the follow-up tests that are kind of silly, we think."
Dr. Tierstein, we have a comment from the audience, and one member from the audience agrees that Sermo is a good idea. That person thinks that JAMA is not a good idea and recommends that you consider using popular media for getting your message out. And then another listener asks your thoughts about the recent Supreme Court ruling regarding antitrust and state regulatory boards. And maybe this ruling might be applied to this issue.
All right, so let me get to both of those. I think I agree that the popular and social media is a great way to go, But I think one of the things that I've noticed about the practicing physicians who are in private practice on this issue is they are a little misinformed about the academics, and they think, well, you know, the academic guys are going to want to have all the certifications. Not true. One of the reasons that I realized this was going to probably work was because the academic community in general is very much against this. If you look at our board, it's mostly academic doctors. And that's not intentional, just I did that because I just wanted to give it credibility. And it's important to realize that most of the chiefs of medicine you talk to, they can't stand doing MOC. They think it's a waste of time also. And if you're a real researcher, if you're a basic researcher doing 21 days a week in the lab, one day a week in the office, seeing patients, and 4 days a week doing bench work, then you really imagine doing MOC in that condition. You're going to spend more time doing MOC than you are seeing patients that year. So they hate it, and that's why I think that the academic journals may be also good places to go. And I think that there is a coming together between academics and the practitioners on this issue more so than you might. The only people really supportive of MOC that I have found are somehow involved with the structure of MOC. They work for it, they consult for it, or they have friends and colleagues that they're close to. So a lot of academic guys have friends who are on the boards of some of these boards, and so that is where they get their support. As far as antitrust, I think that there probably is a way to go there. The problem with that is that's a lawsuit. That's a 3 to 5 year process. And I just think that's a lot of time and a lot of money. And so maybe we'll get there. As you know, that there are several lawsuits, AAPAS, I think is the one with the longest lawsuit, longest running lawsuit. And so I think that's a good approach, but I'm personally not so big on lawsuits. I think I think it's a kind of a nasty way to go about business. I really rather do it, find some consensus and get the boards to change because they want to change. Explain, get them to agree with us and find the common ground. I think that would be more useful. And I think it's possible.
Paul, I want to remind listeners what you said about how does one make change, or what do you attribute the change in the ABIM's course to? And the first thing you said was doctors made their voice clear.
Yeah.
It's such a simple thing that we can do, and all we have to do is do it. In that vein, is your petition then still up and available, and can we link to it on our petitions site?
Really, I mean, I got the web. I'm becoming a minor web expert here now. It's nomoc.org. That's it. If you go there, you're going to get. There's 2 petitions. One is a testifying that you will not do, that you're boycotting MOCs, and the other one is the main one that's your pledge against MOC. And you'll get a link to it. If you go to nomoc.org, you can link either directly to the anti-MOC petition, and link to that site, which will get you to the petition. But you can also link to nbpas.org, which is the national board site where you do the application. And we worked really hard to make this easy. I mean, it should take you 10 minutes to do the application. And then the only problem you're going to have is collecting the evidence that you've done CME. So you have to have the CME certificate. Those of you whose states don't require you to keep it, you might not actually keep them, and that becomes a little bit of a hindrance this year. Next year you'll have them. It's 50 hours over a 24-month process. So it's over 2 years, 50 hours. That's what most states require. But we do need to see the certificate. And the other thing that some doctors have trouble doing is uploading a PDF. Some of you find that funny, but there are doctors that you've got to have a fax way of doing it. You can even send it by mail. I occasionally go to the mailbox, but hopefully you'll maybe use this opportunity to learn how to upload a PDF if you don't know how.
Right.
That could be your CME project.
Right, guys, just Google it real quick. And Andrew, you do have both of those web addresses, and we'll link to them right away.
Hey, Paul, Dan here again. I have a question for you. Just the general kind of bird's eye view, looking at from the big picture healthcare and physicians and the medical profession in terms of viability and overall health in the next 50 to 100 years, it seems to me that a lot of these important issues have been brought up by individual physicians. They are really not, now this is a generalization, the momentum for them and the inertia has really not come out of medical societies, big medical organizations, big institutions. That concerns me a lot as a physician in the medical profession. Thoughts on that?
Yeah, I have a lot of thoughts on that. You know, it's funny, I was just thinking about this the other day when I made this presentation to a group of professors in medicine. Actually, that video is on the website. And one of the questioners got up and he was one of the professors was giving me a little bit of negative feedback, but he started by saying, look, I did my MLC last year, and my secretaries will tell you, my whole office will tell you that I was enraged and I was upset. And hi, I'm looking for Tim. Hello? Hello? This is Kurt Eichenwald.
Oh, hi, Kurt.
Hi.
Hello, welcome, Kurt.
Oh, am I actually in the meeting? Yes, Kurt, you're in the meeting. You're talking to Paul Tierstein. Hi. We haven't spoken much. And you're in the meeting. Yes, you are. Okay. Hello, everyone.
Hello. Listeners, this is Kurt Eichenwald, investigative reporter from Newsweek, who, help me with the article, please.
Who did an investigative series on the ABIM and MOC, and let me just say to both of you gentlemen, it's just tremendous to have you here. Thank you so much.
Happy to be here. I'm sorry I wasn't able to fly out, but hopefully this is a good substitute.
Right.
Well, Dr. Tierstein, I'm sorry, go ahead. Dr. Tierstein was in the middle of a conversation, and
I'll try to be quick about this.
No.
What I should have said, doctor, is how could you have been, as a leader, you know, as a chief of medicine in a prestigious institution, how could you have let this happen to you a year ago and not do something about it? And why do you make me do this? I mean, why couldn't you just call your buddies at the ABIM and say, cut it out? And so what I've learned is that the big institutions and the society, they don't have a lot of, maybe the word is guts. They seem to fear everything. The prestigious hospitals tell me we don't want to be the first to accept MDPAS. I mean, what's the risk? They're not going to kill you. They're not going to fire you. You know, it's like we don't want to go out on a limb. I mean, they're very conservative. They're very concerned about making waves. And I think that's a problem for our medical society because they're important, but they've got to take some leadership. And that goes for. Actually, a lot of the people in society, when you talk to them one-on-one, they agree with you. They say, yeah, I have a lot of friends at the American College of Cardiology who agree. They say, yeah, we should be taking a more strong stance on this. But they don't because they're bored, they're worried. I don't know what they're worried about. There's really not a consequence. It's not like, you know, we're not declaring a war. We're just trying to get our voices heard. Anyway, let's move on to deal with Kurt's stuff too. I can't wait for his next piece.
yeah.
Likewise.
That's one of my questions for you, Kurt. What's next?
Well, if I haven't printed it, I can't tell you.
Okay.
I know you
Okay.
I excited, so.
But
you got pretty upset about this. You got right to the nitty gritty of it, and really saw that there was that this organization really was not being there wasn't being honest and upfront enough. What happened actually is, I saw an article. I think it was in Internal Medicine News, and it was about what Dr. Tierstein was doing. And I hadn't heard of this, and I thought, well, this sounds interesting. And I started doing some research, and I called Dr. Tierstein, and he directed me to his site, and I saw the videos, and I
And it was like, wow, this is a great story. And I called the ABIM, and I have never gotten such a runaround in my life from a supposedly professional organization. And it kept asking for, delay after delay after delay. My favorite was there was one guy in the whole organization who was on vacation, so they couldn't answer basic questions about the operation. And, what I said to him is, you're a $50 million operation. I do not believe that if one person is out of the office, you can't answer questions. And, so they finally provided some answers that were basically just boilerplate things that did not address the questions I was asking. I wrote the story. It was primarily about Dr. Tierstein's actions, but it also was pointing out something that on their own website I found to be, pretty odd, which was that each year, according to them, the number of people, the percentage of people who were passing the test was dropping and dropping and dropping. And on the first try, and I'm talking about the maintenance of certification. Well, if the opening sentence of the piece was, "Are American physicians getting dumber?" Because either there's something wrong with the test, or physicians are getting dumber. And they wouldn't acknowledge that there was something wrong with the test. My favorite was, well, there was 1 year in here where in this one section it went up a point before collapsing again. And I mean, the kind of arguments that no scientist should be making. And the fact that they had no scientific data to back up what they were saying, I found just astonishing. And, just to finish up this story, after the article came out, rather than addressing the issues I raised, they came after me personally. They started going after my wife, saying that I should have disclosed that she was a doctor, which never even occurred to me. I mean, I also have an iPhone, and I write about Apple, and I also, I have many doctors in my family, and that became sort of their line of attack, saying, going after my wife. And I said to them flat out, this is the behavior of an organization that has something to hide. And stop it, or I will really presume you have something to hide. And they wouldn't stop it. And my favorite element of what they did was when they sent the letter to Newsweek demanding corrections. And by corrections, I mean such things as, I said they had a $2.3 million apartment, condominium where their executives stayed. Well, the correction they wanted was that they were going to sell it. That's not a correction. That's not an error. And so, they kept going after my wife, after which I did decide there's something wrong with these people. There's something big wrong with these people. And I started digging into their accounting, and I found out that they have screwed up their accounting for years, that they have a $90 million liability that they can't get rid of, and the way they're figuring out how to get rid of it is by changing the rules on MOC so that you guys can pay them more and fix their massive financial problem that if it isn't fixed, they're going to go bankrupt.
Hey,
So
Kurt,
that's a long story that gives sort of a lay of it.
Going through all that, I don't know how you did it, frankly, going through the financials. I find that stuff very obtuse, very hard to understand. So I'm thrilled you were able to do that.
Well, they make it that way intentionally. I mean, you have to go through many different documents, and there was one filing that, for years they refused to produce. And they only produced it when one person got the governor of Pennsylvania involved to get it released. It's the public document. And, once they released it, they released the first 18 pages without indicating that they had left the rest of it out. And, the guy who had the whole thing tweeted out, now are you going to post the entire thing? And once they did, it became very clear why they left the rest of it out. Because it pointed out a lot of things that were going on in there that if you understand accounting, you could figure out these guys are basically trying to rip off doctors for the purpose of fixing all their financial errors.
Yeah, wow.
Gentlemen, if I could interrupt 1 second, I want to urge people who are webbing in right now, tweet to your colleagues or let them know they should listen to this very interesting conversation between these two gentlemen.
And also, I'd like to take an opportunity to extend a congratulations to you, Kurt. Dr. Stephen Croft in our live chat says, Kurt is a hero, very courageous, and we second that. Thank you very much for what you've done.
Absolutely.
I'm not courageous. I was listening to Dr. Tierstein talk about, what are people afraid of? The ABIM is the biggest organization of wimps I've ever encountered. I mean, I have dealt with corporations. I mean, they're unprofessional. They're incredibly unprofessional. And, they think that, whining and stamping their feet and calling names is a way of dealing with things. And I actually, there's no courage involved. When I was writing about the Russian mob, when I was writing about child pornography, that took some courage. This is just loads of laughs.
Well, you are so right. It's to me as a physician, it's almost approaches the point of embarrassing for some of my colleagues, and it's infuriating. It's a lot of things, right? I don't know. Take a courage. Like you were saying, Paul. Come on, physicians. If you believe in something, then just state it. You can state it without being inflammatory, but have an honest discussion about it.
I wanted to ask you, Kurt, what do you think about the other burdensome distractions on physicians? You mentioned you have several in your family. You may already know more than I do about these things, but there's meaningful use and the money that has caused that to be such an issue. There's ICD-10 piled on top. There's health insurer monopoly behavior. So there's so many things that are piling on physicians right now that distract us from doing what we thought was our job, which for me was keep up with the medical literature, discuss it with my colleagues one-on-one, and then meetings, CME, and then go take care of my patients with it. And then some of these other things, for instance, meaningful use, getting electronic records into hospitals and clinics. That's a great idea, but the way it's working out is just totally distracting from our prime directive. So doctors are it's kind of like we're under attack from 4 or 5 pit bulls at once, and among them are our own societies, such as the ABIM. So my question to you is, are you or other investigative reporters interested in moving on beyond this one issue to some of these other ones? And there was a terrific article in the New York Times, Julie Creswell, February 19, 2013, Shift in Digital Data Swells Profits in an Industry, that really, I thought, got to the heart of the meaningful use problem.
Well, I'm going to have answers that disappoint. I actually don't talk to my family about their jobs, and there's a reason I don't, which is that I know I write about healthcare issues fairly often, and I don't want to know things from them. The only thing I actually do know that I've ever heard about, and I heard about it because I sat with her. My wife is a geriatric specialist, which I have now learned once once the ADIM started attacking means she's an internist. I mean, that's how lame my understanding of things are. I've heard her talk about the benefit of hospice care, and that's basically all I know about. So everything you just listed, I would have to do the research on it. And if you want to send me some links, if you want to send me some information, because I couldn't keep up with everything you were saying, send it to Kurt Eichenwald, it's KurtEichenwald @gmail.com. I love good stories.
Okay, we sure will. Thank you for that.
That's what I have for questions.
I have a Dan Cravioto here again, Kurt, and you mentioned some things earlier, but I want to get you to go into it a little further, like digging into all of this stuff that you did. Did you, how would you characterize the medical profession? Just as an outsider looking in. I mean, you just admitted you had family members, and you don't talk to them, which is fine. So your objective...
But talk to them.
Your objective characterization of the medical profession based on this one little kind of look into one specific area. Any thoughts as a journalist?
I'm sorry, you're not going to like my answer. Well, actually, you probably will, because it sounds like Dr. Tierstein already said it. Physicians are cowards. And I think that one of the things that happens, I've seen medical school training, and I think there is a lot of, you sort of get trained under the concept of fear. Oh my God, I'm doing some sort of rounds with this doctor, and if I don't get the answers right, and I think that fear is an overwhelming part of the medical profession. All of these people, I don't know everything that was being described before, but if it's impeding on your ability to do your job, you are the guys doing the job. And the only people who can get control of this and stop this are not the guys who are making millions of dollars out of your hide. It's you. And you've got to learn, one of the things I said in one of my articles, I think, is doctors need to grow a backbone. Congress needs to hold hearings. And the Justice Department needs to start an antitrust case against the ADIM. The fact of the matter is, if doctors fought back, they'd win. And it's just, I'm gonna tell a quick story because this is what you need to be afraid of. There was a doctor who emailed me from Georgia, and I checked into his patient reviews, and I checked into all this stuff about him. And patients love him. Every indication of quality is there. And he did all of his ADIM stuff, but I don't take tests well. And so, this guy out in Georgia, and he hasn't been able to pass his test. So he is losing his privileges at his hospital, and he is now, he's part of the reason for his problems is he has two disabled children, sole earner, single dad, and he just doesn't have the time to have the practice and all of the extra studies because one of the most ridiculous things is that having the practice doesn't prepare you for the test. And so here is a guy who, in the midst of an internist shortage, is rated well for, getting great ratings from patients, getting people who are traveling for hours to see him, and he's no longer going to be a doctor. and he's no longer going to be a doctor because he's not able to pass a test that has nothing to do with his practice. That's what you guys should be afraid of, because the more internists who drop out of the system, the less power you're going to have. You have the power. You just don't have the courage. Take the power. They can't hurt you.
I agree absolutely with that.
That's so well said. I love it.
Kurt, I'd like to just, since we have about 6 minutes left, just fill you in a little bit on one of those other topics I mentioned. I'll send you some more information. But in my own practice, this has been the biggest impediment to taking quality care of my patients. I had a private practice up until 2010. It was wonderful. A lot was great about it, but I couldn't make money with the financial and regulatory burdens and the shrinking reimbursements. And the government was getting ready to force me to discard my $15,000 physician design EMR, which was tremendous for patient care, and buy a meaningful use compliant government mandated system costing many times more. So I got an offer to work full time at the VA, and I accepted it. And that's where I first ran into that issue, these things they call clinical reminders, where every patient visit the computer would pop up things such as, a lot of them were preventive things, and I believed in them, especially the preventive issues, but you know, in my practice we did those once a year. We scheduled a visit for that purpose, we went through all the preventive stuff, and it really worked out well. So after a few weeks at the VA, someone from the director's office asked me how it was going. I said, well, it's really going well, except for these clinical reminders that pop up for every visit, including the walk-ins we squeeze in. And sometimes there might be 15 of them. And I said, if we would just do that once a year at a designated visit, it would really work great. He said, well, that'll never happen. I said, well, why? He said, because the administration gets a big bonus if you click off all those boxes. And I said, oh, yes. So I had noticed that if we failed to click enough of these boxes within a few minutes after completing documentation, someone from the administrator's office would be down there and standing over our shoulder until we did click those boxes. They never asked, did you do what the box is saying that you did, such as counsel on quitting smoking or something. They only wanted to know that you clicked the box, and they never, in my whole year there, asked, did you address the veteran's concern? So I fought that for about a year. I assumed it was a VA issue, and was unable to make headway, and so I left. I formed a blog called I'mADoctorDammit.org, and I thought I'll just provide a place for doctors to get together on this, get our voices together, and we'll do something. Well, they wouldn't get together. So I took another employed position and found the same thing. And then another, and then in each case, the chief medical assistant would come by, having been instructed by the administrators, who were not physicians mostly, and they would come by and tell the doctors how to practice. This is how much time you'll spend with your patients. This is how you'll document. And I just thought, what in the world is going on here? I've never, in my career, encountered, in 25 years, encountered non-physicians with the audacity to tell physicians how to practice medicine. So I finally just resigned. I realized I cannot take competent care of my patients with these systems. And I quit practicing altogether for a few months and just sort of applied my diagnostic skills to what is the cause of this problem. And as I said, Julie Creswell's article, New York Times, February 19th, 2013, just really puts it together. So recession was on in 2008. The stimulus package was up. One of the stimulus ideas was these doctors and hospitals are slow in adopting computerized records. Many are still on paper. Let's spend some money here as part of the stimulus program and encourage this, which is a great idea. But they formed a commission called Meaningful Use Commission, 23 members. 9 of these were physicians, and only 2 of these were practicing physicians. And her article points out how the IT industry heavily lobbied this commission and Congress to mandate these really unwieldy, complicated, expensive systems, and then Congress appropriated well over $20 billion to have them implemented. And this stimulus, these incentive payments were set up per doctor or per provider, up to $100,000 per doctor. Well, since you had other federal policies encouraging doctors, forcing doctors from private practice into hospitalized practice, on apparently the theory that one gets better care there, which I don't know there's any evidence of. But the private practice is falling dramatically if you look at physiciansfoundation.org biennial surveys. The fact that these physicians were now employed by mostly non-medical people who did not invest in training, did not take an oath, do not look their patients in the eye, and most importantly, do not sign and take personal and legal responsibility for their diagnoses and their treatments orders. They don't have any of these concerns. All they know is if the doctors, their newly employed doctors, click all the right boxes, they'll get this big bonus check. And believe me, they are rabid about it. So I think in my own career, that's been the most destructive to quality patient care, and I hope someone will flesh that out at some point, make the public aware of it.
Well, one of the things, I mean, many years ago, I was writing about what was then called Columbia HCA, which was basically a large-scale fraud,
Hey,
and every
Kurt?
place I reached was fraud. Yes.
I am going to have to move on to our next speaker. We are
okay.
we are very interested in what you have to say, and I bet we will continue this conversation offline. And we just cannot thank you enough for taking the time to join us today. The same with you, Dr. Tierstein. Heartfelt thank you.
Pleasure. Thank you.
My apologies for taking up time, but we will have time during the rest of this week. If you gentlemen, either of you or both, has time and interest, let us know. We will be glad to do this some more.
All right. Email me, call me, let me know.
Thank you.
All right, thanks again.
All right, okay, bye.
Thank you.
Thank you.